So I'm going to move away from the brain stimulation area, but we are still going to talk a little bit about neuroscience, because I'm going to be sort of presenting a broad brush picture of what are some other areas that people have been exploring in research about how we might advance our current treatments for PTSD specifically, and how do we use neuroscience to actually inform that. So I'll be covering a little bit of that, but also then talking a bit more broadly towards the end about some of the other types of alternative interventions that research is currently exploring with PTSD, some of which I'm sure some of you will be familiar with as well. So I think we've already outlined, one of the main issues we've got here with PTSD is whilst exposure-based therapy is our gold standard treatment, it's recommended in all our expert guidelines. This includes imaginal or in vivo exposure. Cognitive processing therapy is also an evidence-based treatment. We've got good evidence that it's effective for about half of the people. But as a clinical psychologist, what keeps me awake is the other half of the people who are either having a partial response or a non-response to our exposure-based interventions. So we've got much research has been done in the pharmacological space over many, many years, a huge amount of funding, and there really are no good first-line pharmacotherapies for PTSD, despite an enormous amount of research. So really, whilst we've got these gold standard psychological therapies that are exposure-based, we still have an issue where we have a significant rate or proportion of people having this non-response. In addition, we do have fairly high dropout rates for our exposure-based therapies, which is another issue that we need to confront. Another really important issue when we're thinking about exposure-based therapy for PTSD is how do we keep people engaged, especially when they're not getting rapid symptom reduction. What some of the research is looking at when they're trying to look at adjunctive treatments for exposure-based therapy, which is what I'll be talking about predominantly today, is how can we actually speed up the response, if you like, facilitate the response to exposure therapy so that we can actually overcome this issue of engaging people and getting people to actually get a symptom reduction earlier and more efficiently with exposure therapy. So the brain stimulation is what Paul's already covered today. I'm going to be focusing more on some of the pharmacological studies that have been done. So there's been a whole range of studies over the last decade or so that have been really looking at what are some of the pharmacological adjuncts that we can use in combination with our exposure-based therapies to try and facilitate and improve our treatment response. So most adjunctive treatments that we've got, especially in this pharmacological space, are based on the neurobiology of PTSD. We know in PTSD that there are particular dysregulations, again, with functional connectivity across these broader networks. So in PTSD, we particularly see dysregulations in the salience network, and that really is our threat detection network in the brain. It's our capacity to recognise threat and discriminate it from safe contexts or safe stimuli, and it really does involve this prefrontal and amygdala type of circuitry or more limbic circuitry. There's also dysregulation in default mode network and the central attention networks as well. But most of the research that's focused around looking at adjunctive treatments informed by neuroscience are really looking within this prefrontal and amygdala sort of connectivity and looking at that salience network. A second aim of a lot of the adjunctive therapies when we're thinking in a pharmacological space is they're really trying to utilise agents that have been shown from animal research to facilitate fear extinction learning. Now, if we look at exposure-based therapies, one of the fundamental ideas or mechanisms underlying our exposure-based therapies is that they involve extinction of fear responses. Our exposure to fear trauma memory, so we're exposing people to either memories of the trauma, or they're going out and exposing themselves to reminders of the trauma on a day-to-day basis, and they're not having an aversive consequence. Over time, gradually their fear will come down. And we think each time they're doing that, that's an example of fear extinction. So what we did was a very early study. Was we actually looked at people and we scanned people in response to a threat stimulus in the fMRI scanner prior to and after exposure-based therapy. And this is just in PTSD patients. We didn't have a control group here, but this has been replicated about 3 times in larger trials with control groups. But what was interesting is we saw a correlation between the amount of PTSD symptom change and these fear extinction networks. So basically what we see is as the PTSD's symptoms improve, you actually get a significant increase in these anterior cingulate regions. Equally, you're getting a reduction in amygdala response. So it's really, again, suggesting, yes, underlying exposure therapy are fear extinction networks and their modulation. So we're going to talk about pharmacological adjuncts. So this has set the scene because we've got this beautiful translation between fear conditioning and extinction. We know that these networks are fundamentally dysregulated in PTSD, but they're really key to exposure-based therapies. This has led a lot of neuroscientists to get very excited and to think, okay, if we can actually go back to our animal research and we can uncover some kind of molecular mechanisms that influence fear extinction, perhaps we can trial these as pharmacological adjuncts for during exposure therapy to try and facilitate our response to exposure therapy. So these are just some of the agents that people have trialled. So in summary, with pharmacological adjuncts, it's not looking like a compelling story. It's fascinating neuroscience, but sadly, clinically, we're not getting anything that's really that compelling or exciting yet. So I also just wanted to briefly mention there's about 3 randomised controlled trials now starting to look at exercise as a adjunctive combined with exposure therapy. Animal and human studies using fear extinction have found that brain-derived neurotrophic factor, or Bdnf, actually can facilitate fear extinction learning via activations, again, in prefrontal networks. We did a study where we were measuring Bdnf via looking at the Bdnf genotype, and we found that people with the low expression Bdnf actually had impaired fear extinction learning in PTSD. We also genotyped some of our patients who went through and did prolonged exposure, and what we actually found, again, was the people who had the low expression Bdnf allele had a poorer response to exposure therapy than those who had the higher expression Bdnf allele. So this led us to the question, if that's actually slowing and impairing if you've got lower levels of Bdnf and it's impairing your treatment response, if we can increase Bdnf levels, would we actually be able to facilitate response to exposure therapy? And one of the most robust ways of increasing Bdnf levels is actually via acute aerobic exercise. So this has now led there's about 3 different groups now who are getting people to come into the clinic, cycle on a cyclometer for 10 to 15 minutes, trying to get them to a certain VO2 max to raise Bdnf levels, and then they're immediately doing exposure-based therapies afterwards. None of these studies have yet got any data coming out, so it's in the experimental phase. But something that excites me about that is the dissemination potential. I think that many clients actually are attracted to doing exercise, and clinicians also feel comfortable with working with exercise. And I think also it may have benefits for physical health, where we know our PTSD patients often have metabolic syndrome, cardiovascular issues and so forth. So jury's out on that one. Virtual reality, just briefly, we know there's an increasing evidence for the efficacy of VR-enhanced exposure-based protocols, especially for military veterans. So they've created really sophisticated VR environments around Iraq and Afghanistan, and they're showing in several trials now good efficacy with the VR therapies. However, they haven't compared standard PE to VR PE as yet. I think that's underway. Also, some interesting new developments are looking at surround sound VR, or sort of a surround VR environment, these Karen systems, and they're trialling people actually moving and walking towards threats in their environment. I just wanted to mention mindfulness interventions because it's certainly increasing evidence is suggesting that mindfulness may be an effective intervention for reducing PTSD, but also for general anxiety and depression, often comorbid with PTSD. The research evidence for mindfulness was really quite poor for a long, long time, but increasingly there's now RCTs that are looking at active controls compared to these mindfulness interventions, and they are finding a significant effect of reducing PTSD symptomatology. Assistance dogs is also another area that people are very interested in, especially with veterans. And there are several trials. Again, there's been some smaller case series studies going on looking at the effectiveness of assistance dogs, but there's ongoing trials happening currently. And just the intensive treatments as well. So Phoenix has been doing a Restore trial looking at how do we deliver prolonged exposure. So often it's very hard to get a client to engage in very intensive exposure therapy over a 10-week period. So there's now been 3 or 4 trials, and Phoenix is currently doing one, looking at comparing doing prolonged exposure on a daily basis for 10 days compared to weekly basis for 10 weeks. And some of the early RCTs coming out there are showing some really promising effects that it may be equally effective. So again, just giving us some flexibility in how we may be able to deliver some of our interventions. So in summary, while we have established treatments for PTSD, we've got limited efficacy. We've still got 40-50% of clients only showing a partial and inadequate response. So it's crucial we find ways to improve our treatment response and find alternative evidence-based interventions. Much interest in the pharmacological adjuncts, but really it's not looking very promising at all in terms of the research that's currently coming out. Brain stimulation therapies are certainly looking promising, and I think will be developing significantly over time. Mindfulness interventions also are appearing promising as an alternative intervention, and there is a potential for exercise protocols and some of these more VR-enhanced protocols into the future. Thanks.